and you wanna settle that scar, but you're bruised and beaten, and you feel defeated. This goes out to the heaviest heart. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up, it's not over. Yeah, whoa. Yeah, whoa. Oh, game, set, match. Time to put it in your past. Oh, feel the winds are leaving. It's redemption season. Long live the young at heart. Here's to a brand new start. We're revived and breathing to live a life of freedom. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up, it's not over. Yeah, whoa. Yeah, and life is a race we run, so run till the race is won. Don't you ever give up, no, never give up. Life is a race we run, so run till the race is won. Don't you ever give up, we will never give up. To everyone who's hit their limit, and even when you think you're finished. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up, it's not over. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up, it's not over. Yeah, whoa. Yeah, whoa. Oh, to everyone who's hit their limit, and even when you think you're finished. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up, it's not over. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa.
Welcome to our new series of advocacy webinars. Today we have the pleasure to be with Professor Martin Brodie. Professor Martin Brodie has directed the Epilepsy Unit in Glasgow, Scotland since 1981. He has published more than 500 editorial chapters, reviews, and scientific papers. He was secretary and then chair of the Commission on European Affairs, CEA, of the International League Against Epilepsy, ILAE, from 1993 until 2001. He was vice president and treasurer from 2001 until 2009. He has set up the charity Scottish Epilepsy Initiative in 2003. Professor Brodie has received the European Epileptology Award from the Commissions on European Affairs, the Epilepsy Lifetime Service Award from its UK chapter, the William G. Lennox Award from the American Epilepsy Society, and the Epilepsy Lifetime Accelerator Award from the Epilepsy Foundation. He is the current president of the International Bureau for Epilepsy, IBE. The learning objectives for today are, give me just a moment. Oops, I lost them. Provide guidance on specific issues related to epilepsy. Communicate information about the causes and consequences of the specific type of epilepsy and its treatments. Counsel patients about medication taper and discontinuation. Counsel women of childbearing age about the implications and management of epilepsy. Provide information and explain to a patient the concept of sudden unexpected death in epilepsy and advice on the associated risks. Provide counseling on issues specific to the elderly with epilepsy. Provide counseling specific to children with epilepsy and their parents, according to the epilepsy types. Provide counseling and information in relation to PNES to patients and families. So without further ado, I leave you with Professor Martin Brodie, who is speaking for us today. Thank you, Dr. Brodie.
Hello, everybody. I'm speaking to you from Scotland. The rain has just gone off, the sun has just gone down, and it's now night time and time for me to have a whiskey. But before I have a whiskey, I want to talk to you for the next hour or so. The list that you heard is really a little bit long for me to do in about 40 minutes. So I'm going to pick up on the aspects of treatment and counselling that are relevant to my expertise in my clinical practice. And the title is Counselling Patients with Epilepsy and, of course, Families and Carers. And here are my declarations of interest. I'm going to mention a number of relevant factors that I deal with every day in clinical practice. Seizures and syndromes, what is the problem and how much to tell the patient. Psychiatric comorbidities, very common and very important. Medical comorbidities, often not dealt with by neurologists, but will be dealt with by other specialties. The damage of enzyme induction and why we need to avoid it if we possibly can. And of course, the issues surrounding teratogenesis, which have changed our clinical practice really around the world. I'm going to focus a little bit on older people and choices for them and issues surrounding people with learning disabilities. I'm sure all of you will have seen this slide from Ingrid Schaefer, and this is a slide that every one of us epileptologists use because it covers everything we know and we want you to know. Seizure types, focal, generalized, unknown, of course. Epilepsy types, focal, generalized, a bit of both, or unknown, leading to hopefully the recognition of epilepsy syndromes. Why? Why may be structural, why may be genetic, why may be infectious, why may be metabolic, autoimmune, unknown. Patients need to know that. And of course, the issues of comorbidities, which are often relevant to the clinical practice. So all of this it has to be discussed with our patients as we make the diagnosis and go forward with the treatment. And the partnership that we have with people with epilepsy and their carers are essential to get the best outcome for everybody. So does it matter? Well, it matters. You know, when you see a patient, a young woman or a young man with juvenile myoclonic epilepsy, you know what you're dealing with. You know what to do. You know what to say to the patients and the family. And I show them the EEGs. If they've got a brain neoplasm or cerebrovascular disease, they need to know that that's the problem and that's the cause of the epilepsy, and we can do something at least about it. And of course, if we have terrible disorders such as Lennox-Gastaut in babies and progressive myoclonic epilepsy in young children and teenagers, that's a huge deal. But patients are entitled to know what we know. And so we have to know what we're talking about. Psychiatric comorbidities have really become increasingly important over the last 10, 15 years. And we know that now that something like 25% of patients with newly diagnosed epilepsy and 50% of patients with refractory epilepsy have a psychiatric comorbidity, such as bipolar, such as psychosis and anxiety disorder, autism, depression. And it's maybe not surprising because the mechanisms overlap. This is still the brain, and the brain is disordered. And I need to know that when I'm seeing the patient for the very first time, and I need to take that into consideration when I'm making the decisions for them in terms of treatment. Medical comorbidities. There are coexisting medical conditions resulting in epilepsy, particularly in the elderly. Problems arising secondary to epilepsy or its treatment. Medical issues developing during a lifelong course of epilepsy. And that's got to be considered because they may be relatively young when you first see them, but 20 years later, they may have vascular disease and other problems that you have to be aware of and identify if necessary. Are these problems do they cause the epilepsy? Are they due to the epilepsy, or are they just chance? Because we're treating the patient, we're not treating the seizures. So medical comorbidities is a whole list of papers that you ought to know about and read. Higher risk of stroke, migraine, dementia, brain tumors, other cancers, cardiovascular disorders, obstructive sleep apnea, anemias, hypertension, diabetes mellitus, etc., etc. So this is not just about EEGs and seizures. This is about a person, medical disorder, medical condition. What are important considerations these days? I'm going to just touch on, as I said at the beginning, a number of issues that I think are relevant. I don't use enzyme inducers anymore, such as carbamazepine, we'll come to that, because of the problems that they cause when we have drugs that don't cause these problems. Enzyme inducers stimulate the de novo synthesis of metabolic enzymes, thereby reducing the duration and intensity of action of a wide range of lipid-soluble drugs. Each inducer can produce a different spectrum of increased enzyme activity. If you want to know a bit more, there's a very nice review that a number of colleagues and I published in Epilepsy in 2013 at the bottom there that you can look up, because it's a complicated situation. What are the enzyme inducers? Well, we don't worry too much about phenobarbital and primidone anymore because we don't use them that much. But carbamazepine is certainly an important one, and to a lesser extent, oxcarbazepine and eslicarbazepine, and they are a narrow spectrum enzyme inducers. Consequence of enzyme induction: enzyme inducers accelerate the clearance of many lipid-soluble drugs, and most drugs are lipid-soluble, about 80%. And that drops the blood level of these drugs per dose by about 50%. And so withdrawing the enzyme inducer doubles the concentration. And if you don't know that, you're going to get into trouble, and the patients are going to get into trouble. So we've got everything you can think of: contraceptives, warfarin, cytotoxics, antiretrovirals, immunosuppressants, and of course anti-seizure drugs. So you need to know about this, and you need to know particularly if a patient is taking one of these enzyme inducers, or whether you start it or somebody else starts it. So potential problems with induction are unwanted pregnancies, the effect on the oral contraceptive, increased cancer mortality, progressive AIDS, transplant rejection, uncontrolled hypertension, breakthrough pain, and of course uncontrolled epilepsy because of the effect on anti-seizure drugs too. What we have to do when we start seeing the patient is to figure out into what category that they're going to fall into. Pattern A are seizure-free immediately or within 6 months of starting treatment and continuing throughout follow-up. They do fine and on a modest dose of pretty well anything, and that's about a third of patients. Some 22%, 20% have a delayed response for more than 6 months after starting treatment, then seizure-free throughout follow-up. So it takes a while to get the seizures under control, partly because you have to find the right medication, and also because the patient has to agree to take it in the correct way. About 20%-ish, around about, patients have fluctuating epilepsy. They have periods of seizure freedom lasting a year or more, followed by recurrence, and vice versa. And they can come and go. They can have some one pattern for 5 years and then another pattern. And the last pattern, of course, is about 25% who are never seizure-free for any complete 12-month period, because what we prescribe are anti-seizure drugs, not anti-epilepsy drugs. The drugs deal with the symptoms; they don't deal with the cause of the symptoms. Most patients reporting more than one well-documented or witnessed unprovoked seizure should be offered drug treatment. With a few exceptions, widely separated seizures, and they may be 10 years, 20 years, and possible provoked episodes until you figure out what the provocation is and prevent that. If the patient's not sure whether to take medication, or if you're not sure whether the diagnosis of epilepsy is correct, then wait. It does help if people can phone you, if families and patients can phone you if something goes wrong, because quite often it's in my clinical practice, persons walked out of the office we're not knowing what's happening, gets on a bus and then has a seizure, and they can't get on another bus and come back. They have to get another appointment, and that can take some time. So we've always made it easy for people to, particularly in the first seizure service, for people to phone up and for families to phone up and get appointments, get walk-in appointments. If you can't do that, it's not easy to treat newly diagnosed epilepsy. When do we treat a single seizure? Well, the numbers depend on the paper that you read. If there's an appropriate focal lesion and they have a focal seizure that sounds as if that could be the lesion that's causing it, then why not? If the EEG is abnormal, like a few jerks, and the EEG shows juvenile myoclonic epilepsy, then why not? And there are some scenarios where a patient who's had one seizure and lost his driving license and is likely to lose his job, says, okay, will I have another seizure? They said it's possible. It might even be likely if I have something on the EEG or an imaging abnormality. And so the patient might say, right, well, okay, let's just get on with the treatment. And then at least after a year, hopefully I'll be able to get back to work and get back to driving again. But clearly there are multicultural and geographical differences in these decisions, in this discussion, and this conversation, whether you have it in your part of the world or in my part of the world, or even in your clinic or in my clinic, because doctors do different things and say different things, even though they may think they think the same. Areas for discussion with patients and family. What type of seizures are they? Do we have syndrome classification? What do we think the outcome is going to be? What choices of treatment are available? What sort of side effects might one expect? Whether are comorbidities relevant? Is the medication that the patient's already taking relevant? And we discuss the positive and negative aspects of starting treatment, including SUDEP. I talk about SUDEP right from the very beginning, and I document it in my notes, because if every now and again somebody dies on you and you haven't mentioned it and you haven't discussed it, and that's a disaster for everybody. And that certainly is very important for persuading people to take the diagnosis of epilepsy and take the treatment. It's difficult when you don't know if the seizures are actually epileptic seizures, and then I think it's reasonable not to say anything. But if you think it is, then you have this combination, this discussion. And it's interesting, patients don't think they're going to die, and we often have to persuade them to actually take the medication, which is an interesting situation. The goal, of course, is no seizures and no side effects. If the patient's having lots of seizures and I'm not sure where we're going, I'm able to arrange frequent clinical appointments and appointments with the family in the epilepsy unit. Patients' access to clinical staff optimize the likelihood of success, that they get one doctor and one nurse and they know what they're being told is consistent. Continuing dialogue is essential to ensure seizure freedom in a compliant and reasonable patient. They talk to you, you talk to them, we all talk to the partners and the families, and we bring them in. So that when you're a teenager, your mother and father come in; when you're an elderly person, your children come in, and you have the same conversation, and just in a different direction. Side effects. My patients do not blame me for the seizures, but they do blame me for the side effects of the medication I've prescribed for them. And so it's very important to ensure that you are able to discuss the potential side effects with the patients that you treat. So make a habit of two things, said Hippocrates: to help, or at least to do no harm. The commonest side effects, of course, are type A adverse effects, which can be attributed to the drug's mechanism of action and are usually dependent on the dose. And often it's because you went too quickly with the dose and you increased too high. The higher the dose, the most likely they are to occur. And the reduction in dose often improves or abolishes the problem. But if the seizures are not controlled and the side effects come in before that, then you may as well give up and start another drug. Common problems include dizziness, fatigue, headache, and side effect and ataxia. So you need to discuss it with the patient, saying, if it happens, let me know and we'll sort it out. And these effects, of course, are more likely to occur in people taking other drugs, such as antidepressants. So older people, older patients will be on other medications, and you need to know about these too. Specific problems that you need to know about. Everybody, I think, knows that valproate causes tremor. And if the tremor is a problem, then the valproate has to be reduced or stopped. But many of you will not know that insomnia is a problem with lamotrigine. You might know whether word finding difficulties occurs with topiramate, and you might mention that to the patient. But you might not know that perampanel causes falls. And if you don't know, then you don't diagnose it and you don't ask the patient about it, and the patient doesn't tell you about it. So we need to know what we're doing. Type B adverse effects are uncommon and usually related to individual immunological or genetic variability. They can result from a mild rash to severe life-threatening disorders affecting a range of organs in the body, and usually occurs within a few weeks or months of starting a new anti-seizure drug. Early recognition can be life-saving, allowing the drug to be rapidly withdrawn. Again, my patients are told, here's the number to call if a problem arises, and they have the office number, and if anything goes wrong, I need to know before real trouble starts. So, of course, the obvious ones are Stevens-Johnson syndrome, which we see from time to time, and there's a genetic component there. There's a genetic component with all of them. Particularly with carbamazepine and lamotrigine and maybe oxcarbazepine. But of course, there are a number of other more severe problems, such as Stevens-Johnson syndrome, toxic epidermal necrolysis, hepatotoxicity, blood dyscrasias, pancreatitis with valproate, lupus-like syndrome. You need to see these patients really very quickly if things go wrong like this. They don't happen much, but again, you have to tell them, if you have a problem, let me know as soon as possible. And as soon as you can, you stop the medication, then you see the patient. Because if you hang around, it gets worse. Discussing adverse effects. Well-informed patients are better able to distinguish between likely adverse effects and other symptoms. And certainly in the UK, they'll get a list of them from the pharmacist, sometimes a long list, which makes them anxious. They'll also need to know some of the rare, potentially serious adverse reactions. As I said, if you have a rash, let me know immediately. So package inserts with the medication can be helpful, but it also frightens people, as can discussion with the prescribing doctor or the pharmacist. Now, this next quote came from a court case in a fatal accident inquiry where somebody died of an idiosyncratic reaction. And the judge said, people with epilepsy should be told whatever they want to know and not what the doctor thinks they should be told. And that's the bottom line. Ask the patient, what do you want to know? What can I tell you? What's your concern? And then hopefully things will not go wrong. Drug choice. As there are no major differences in efficacy amongst first-line anti-epileptic drugs, and that's another lecture, tolerability and long-term safety must be paramount consideration in patients with often mild newly diagnosed epilepsy. As I say, initially, the driver is the tolerability and the side effects, not the efficacy. That comes later. So what anti-seizure drug to choose first? Pick a drug with a spectrum of activity and side effect interaction profile that clearly has the potential to produce seizure freedom without long-term sequelae in that particular patient. Match the choice to the patient's seizure and/or epilepsy syndrome, gender, age, weight, psychiatric and other comorbidities, risk of teratogenesis and concomitant medication, etc. And that's a lot to take in one little sentence, but that's the deal when you see an individual patient with newly diagnosed epilepsy. And in some parts of the world, not in mine, but in many parts of the world, cost must also be taken into consideration. So if the patient has a psychiatric comorbidity, you might consider using an anti-seizure drug that actually benefits people with these problems, such as valproate, lamotrigine, carbamazepine, even though I don't use carbamazepine anymore, but I do use clobazam, and occasionally I use topiramate, and I use pregabalin, but not gabapentin. If there's a psychiatric comorbidity, then you have to consider whether you want to prescribe topiramate, levetiracetam, zonisamide, or perampanel, or if the problems arise, whether you want to withdraw these drugs. And a psychiatric history is a predictor of problems. So if the patient has a psychiatric history, these are not the drugs to start on the first or second attempt. Major congenital malformations, and this is a valproate exposed child, baby who died. And valproate, of course, is the big issue here. A risk of major congenital malformations assessed at 1 year after birth from Tubby and Thompson's data, and something like 10% of kids exposed to valproate have a risk of major congenital malformations. But other drugs do too, and if there's a lot of data around now, but if you look at different registries, you get different numbers. But valproate always wins, and then usually phenobarbital follows, and often topiramate after that. But it's possible that all the drugs can be teratogenic in the individual circumstances. But these are the three big problem drugs in this setting. So if you use a lower dose of valproate, then you get less of a problem, but it's still there. And I certainly find if I tell a young woman that this drug can malform your baby, they don't take it, and I don't give it to them. And then it's my problem. I have to make sure I can treat their epilepsy without it. but I don't give it a go and hope for the best, because problems arise and people die. I've got one certainly patient with SUDEP who refused to take valproate, and she died. Because the issue with valproate is that this is cognitive function after fetal drug exposure. Low dose, no problem with valproate, as you can see. High dose, yes, there's a problem. Mean IQ at age 3, this is from Kim Meadows' work. So high dose valproate is a big deal, and so we don't use it. These are twins, believe it or not, who attended my clinic for a number of years. And the thin one in 1996 had JME. The fat one in the black also had JME, but the fat one refused to take valproate, and the thin one refused. She was, known at school as a fat twin, and the valproate was the problem. And they both had JME. Unfortunately, the valproate worked, and the drug was withdrawn. And 10 years later, she'd lost weight and she was looking good, still taller than her sister. The lamotrigine that I gave the other girl didn't work, and she ended up on valproate, and she had she gained weight, as you can see. And unfortunately, she had a child with autism. And I guess that was my fault. And that was a long time ago now. We wouldn't do it now. Childhood autism is about 5 times more common than in kids exposed to valproate compared to the other anti-seizure drugs. And that's the reason why we're now not using it. So the pregnancy prevention program in Europe says all patients, you have to have consent to treat all young women who are planning on becoming pregnant. They should be pregnancy tested before starting and during treatment as routine. They should take effective contraception throughout treatment. And they should have annual reviews, including completion of risk acknowledgement forms, which are made available. This is from the European Medicines Academy. And they said valproate must no longer be prescribed to women or girls of childbearing potential unless they are on PP or on the PPE, which is a pregnancy prevention program. Does that happen all over the world? No, but it's increasingly commonly happening and will almost certainly happen. And it's very difficult to treat JME in young women without using valproate in many circumstances. The commonest time to develop seizures is in old age, about 3% in the over 80s. But on the positive side, the outcome's usually quite good. And the patients on the medication, I don't call them anti-epilepsy drugs, I call them drugs for your turns or whatever else. I don't talk about seizures in older people, or they won't take it. So increasingly, I'm using lacosamide. I'm still using lamotrigine. And I'm starting to give up on levetiracetam because of the behavioral side effects. But now and again, I'll use a small amount of valproate at night if there's no tremor. And as I say, I suspect the next time I set the slide up, I might have lacosamide first. Partly, not because of any difference, but partly because it takes a while for lamotrigine to get into steady state, because it's got a longer half-life than lacosamide, which will get into steady state quicker. And most neurologists are doing the same thing. Learning disabled patients, they usually have multiple seizure types, and so we tend to use broad spectrum agents in that setting. But obviously, if the patient has weight issues, you wouldn't use valproate. You use a weight-relevant drug because they don't get that much exercise, and you don't want to make them overweight. Behavioral problems, we avoid benzodiazepines such as clobazam and levetiracetam. And the more you talk to people about behavioral problems with levetiracetam, the more we all see it, and it's at least 30% of patients who take the drug. Less so with brivaracetam, but brivaracetam is usually a bit more pricey, and so less likely to be used. When to substitute? Choose another drug if the first drug fails due to a rash or other idiosyncratic reaction. That's an easy one. If there's poor tolerability at a low dose and you haven't got the seizures controlled and you're starting to talk about side effects, then change it. And no improvement at all in seizure control, then you just change it to something else, something that works in a different way with a different mechanisms of action. Again, that's another lecture. When to combine. If the patient tolerates the first or second drug well with a useful but suboptimal response, combination therapy should be considered, particularly if there's a high pre-treatment seizure density and demonstrable underlying pathology such as MTS or cortical dysplasia. And when you see something on the imaging, it completely changes your attitude to how you're going to manage that patient. And I actually show the patients and the family the EEG changes, and I show them the imaging changes, and I say, this is the problem, this is what we need to do, and we can work together on how we're going to get you seizure free if we can. The greater the drug burden, the less likely will monotherapy and polytherapy be tolerated and therefore effective. And as I said to you, the patients don't blame me for the seizures, they blame me for the side effects. And so the drug burden is a function of dose as well as number of drugs. So make sure you don't poison the patient while you're trying to treat the seizures, and take the doses down as soon as the patient complains. And then you can add in another drug and take the dose down again until you get a combination of 2 or 3 drugs that makes the patient seizure free. Again, that's another lecture for another time. Guidance for combining drugs. Establish optimal dosing of the baseline drug and add a drug with a different mechanism. So take the dose down if the patient's got any side effects or even thinking about side effects. Avoid combining drugs with similar modes of action and go slowly and carefully. And you can take the dose down of the original drug quite a lot, but keep it on board. If you can, then you can get a combination of the 2 drugs rather than trying to find another combination. And if response is poor, you can replace either drug, and you can use 3 drugs is still suboptimal control. I have a number of patients who are seizure-free on 3 drugs, many patients who are seizure-free on 2 drugs, but only 6 at the last count who are seizure-free on 4 drugs. What we want is seizure freedom, and quality of life relates to no seizures, not how many seizures you have. Because if you have 1 seizure a month, you still have a bad day every month and you can't drive a car. So you really want to try and get the number down to 0. If you can't, then you need to make sure that the seizures are as less of a problem to the everyday life of the patient as you possibly can. Sometimes I take a rest, the patient and I decide we'll not see each other for 6 months, and then we'll see what other drugs I can offer them, and we'll take things from there. And they can always call if things go wrong. This is a big problem. How do we prevent people with refractory epilepsy from receiving treatment with too many drugs? And this is a big issue for neurologists who chase seizures and don't treat people. I mean, this is about people. This is not about epilepsy. This is not about seizures. This is not about EEGs. This is about people. So you always discuss the situation frankly with the patient and the family right from the beginning so that they trust you. It still doesn't mean you can get everything right, and sometimes they'll go and see another doctor, and that's fine. I have no problem with that. But you always be frank with them and tell them what you know and what you think, and they will work with you, even if they continue to have some seizures and you can't stop them. At least do the best that you possibly can. So a range of established and modern anti-epileptic drugs are available with different mechanisms of action, pharmacokinetics, spectra of efficacy, side effects, and interaction profile for the treatment of epilepsy. We should make an effort to choose the best monotherapy or combination therapy for each individual patient. And remember, the patients are partners. We used to sort of think they worked for us, but they don't. We work for them, and we're all in it together. And don't forget to bring in husbands, wife, parents, children, everybody who is relevant. Ask the patient, ask the family who wants to come in, who can we talk to. They maybe have questions that the patient doesn't ask. And all of this is going to end up with a better outcome in the long term. And lastly, my friend Albert Einstein said, make things as simple as possible, but no simpler. Thank you very much.
Thank you so much, Professor Brodie, for such a wonderful talk and very illustrative of how we have to manage and talk to patients about their treatment and about their comorbidities. That was very interesting. I do have one question. Would you give us like a tip or an advice on how to start the difficult conversation of SUDEP? How do we start that conversation?
Yeah, I don't have a problem with that. And I say seizures are dangerous. That's why we need to treat it. People die of seizures. People die during seizures. They don't believe you. I don't know why, but they don't believe you. But if you don't tell them, they then say, nobody said. The family said, nobody said, nobody said. And I have families where the patient's been seizure-free and the mother withdrew the lamotrigine, and this 29-year-old seizure-free lady died. And when she phoned up, I told her, you didn't let her take. She knew, the patient knew that she wasn't to stop, but the mother didn't because she was never in the conversation. And I never have had a problem with that. You know, that's why we're treating you. These are dangerous. People die. Then, you know, if you ask you questions, that's fine. But and then you document it, because now in the UK, if you don't document it and the patients take you to court, you're in trouble. You know, they'll say they never knew. They did know, but you haven't actually written it down. So increasingly, with what we now know, if you're seeing patients and families together, make sure they know this is why this is serious. This is why you're here. This is the problem. You know that you know you can give them a bit more explanation if they want it, or they can look it up on the net, and many of them do. But it's criminal now not to mention it, particularly in difficult to control epilepsy patients, because they are at risk, and we all know that they're at risk. So as I say, but I'm comfortable talking to people. I'm comfortable talking to you. You know, some doctors are less comfortable talking to patients than others, not because they're bad doctors. They just are a little bit quieter doctors, and I'm not quiet, you know. So you have to learn to do it professionally, to be, you know, to say to people professionally, this is what you need to know, and to make sure that nowadays that you document. I mean, it's, to be honest, it doesn't happen very often, but when it does, you never forget. Just never forget.
We have another question. Do you have a strategy on how to engage patients who are not willing to take medications, even when you have discussed SUDEP risk?
Yeah. I think the most important thing, again, is to give them the information, to say that you're giving them the information, to talk to the families, and to document that you are worried that this patient's not taking the medication. Having said that, they're entitled not to take the medication. That's, you know, they're entitled not to get the COVID vaccine. You know, it's a big conversation around the world, isn't it? Why would you not? I've had it. Why would you not? But some people won't. And I have many patients who wouldn't take the medication. I have many other patients who like me and don't tell me that they aren't taking the medication. So I think the most important thing is to give them the information, speak to the family, give them the opportunity to come back. And I said to one guy, you know, okay, you don't want to take treatment. When you have your next seizure, will you phone me? 2 days later, he phoned me. So, you know, you can be smart about it, but there's still some people that will say, no, I'm not going to take it. And as long as you cover yourself, cover it with the family, because the family will say, she never knew, or he never knew. Because they knew, and they feel guilty enough, so it's your fault. But you're quite right, it's a very, very worrying situation for us in epilepsy. And as I say, you know, I've published a number of publications on our outcome data on the SUDEP, and you just never know. What surprises me is how few people die, you know. But so I don't know whether that's the answer to your question, but at least it will allow you to think about it and allow everybody listening to think about how they would do it. But if nothing else, make sure that you cover yourself, so you don't get accused of being negligible when you're not, negligent when you're not.
Yes.
And
We have another question. How to balance giving common side effects in anti-seizure drugs information and avoid over alerting those patients that maybe are too anxious to take the risk.
Yeah. No, I know. I mean, that's what I have a problem with when they get a big piece of paper from the pharmacist, because the pharmacist gives them the drug that I prescribe, and it's got a list of side effects as long as you're on, because it's put in all the side effects that was ever reported during the placebo-controlled trial, including from the placebo bit of the controlled trial. So I think you just have to explain that this is what we do, and we need you to know what the bad things are, but the bad things don't happen very often. But you can see how much trust is so important. That, if the patient doesn't trust you, if the patient doesn't believe you, they're not going to do it. That's why I bring that conversation in very, very early, because as I say, if the medication causes problems, it's my fault. But if they continue to have seizures, they don't blame me to the same extent. But there will always be patients that you can't win, and certainly you can't win in the first pass. You have to say to them, well, okay, I'm going to leave you to do this, and if I'll see you back in a couple of months' time. If you want to see me in between, but you will have more seizures and you will give up, and I laugh. Not everybody can do that. When you're old and grey like me, I'm going to say, I win. You can try and beat me, but I win, because the seizures will beat you, and then you'll come back to me. And they mostly they do. But again, document it, because as I say, it's so serious when something like that happens for everybody.
Perfect. Well, thank you so much, Professor Brodie, for such a wonderful conversation. Oh, we have one more question just came up. Let me please read it to you. Is it real that a side effect like headache to be reported to all medication added in the same patient?
Sorry, I wasn't quite sure. If the patient has headache, is it definitely a side effect? Is that what you're saying?
Exactly. That I think is the question.
No, not necessarily. And obviously headaches are so common. So you have to look at the timing of it. You have to look at when they're taking their dose and when the headaches, and of course the semiology of the headache is a migraines, and if you don't know, switch it. I mean, so many times I've sent patients back by colleagues from another discipline saying this drug is causing this problem in this patient. And I write back and say, no, it's not. And they say, yes, it is. And I said, okay, I will change it, and then I'll send the patient back. And then next time, don't send them. Because they don't know. I know because it's my business, but they don't know. So the patient says, this is the problem. So it's somebody else to fix it. And somebody else will be me. But if the other consultant insists and the patient insists, you can't resist it. You can just say it's not going to happen, but I'm going to do what she asks you to do, but you'll still have the problem with the headache. But it's in my court. It's my decision. So if they want me to do it, unless I think it's at risk to the patient's life. But of course, with the best will in the world, the patient is asking me to do it. So you can't sort of really say no, unless sometimes I won't change a medication if I think really it's going to be life-threatening. And I've had that patient in my books for years, and I say, you need to find another doctor. I can't see you anymore. That works.
That works. Okay. Thank you so much. There are no more questions in the chat. So we again thank Dr. Brodie for such a wonderful conference. And we hope to see everyone soon on our next webinar that is going to take place the 6th of March. Thank you so much.
Good night, everybody. Bye-bye. Cheers.